All right, we're going to go ahead and get started. Thank you all for hosting me and letting me give today's Grand Rounds presentation about the changing landscape of obesity medicine and bariatric surgery, or weight loss in the GLP-1 era. So, a little about me. I was born in Kansas, raised in Kansas, went there for undergrad and med school, did my residency up in Chicago for general surgery, and then went to Kansas City for bariatric and foregut fellowship. I'm currently a part of Capital Surgeons Group, and I've got a little shameless Jayhawk plug down here at the bottom. As far as disclosures, I've got nothing to disclose. And here's the outline. So we're going to go over obesity definitions, rates, stigma, costs, and then weight loss, practice changes, as well as medical, surgical, and combined weight loss. So let's first define obesity. Obesity has a lot of different definitions, a lot of different ideas of what it is, from the most basic of an abnormal excessive accumulation of fat to the most comprehensive, where it says it's a chronic relapsing multifactorial disease where an increase of body fat promotes adipose tissue dysfunction and abnormal physical forces, resulting in metabolic, biomechanical, and psychosocial health consequences. And obviously that's a mouthful, so it's easier just to go with the less comprehensive ones, but it's still a good framework to state that it is a chronic relapsing disease as opposed to just an accumulation of fat. And obesity rates, as we know, are on the rise. In 2023, it was 40.3%, which is a slight downtick actually from 2020, which was probably kind of peak COVID when everybody was sitting inside, but still above the 40% threshold. But severe obesity, or a BMI of greater than 40, continues to be on the rise. It's reaching almost 10% in 2023 and probably higher now. So first, the stigma of obesity and weight bias. Generally treating obesity as a character flaw and not a chronic illness. So things like saying, why don't they just quit eating and work out more? They're cheating if they do medications. They're taking an easy way out if they do surgery. They're just lazy, or they did it to themselves. Now, education is the first step to destigmatization. So when people are educated in multiple causes and treatments of obesity, they're statistically shown to have less bias. And the popularity of these GLP-1 medications has also helped to decrease that bias and allow people to talk about obesity more openly. And as more patients are going to be treated for this disease, more patients are going to be in the medical and surgical arms, for increases overall. So it is more than just diet and exercise. There's a genetic component. If both of your parents are obese, you have an 80% chance of being obese yourself. If only one parent is, you still have a 50% chance. There's a ton of hormones that go into it: cortisol, ghrelin, leptin, and many others. And it's just this neurophysiology of the gut-brain axis, what I'll get into on the next slide. Gut health, processed foods, and sugar in everything. Obviously, there's a big push towards more healthy foods, but there's still a ton of these processed foods that are very easily available on the market. And sleep. Poor sleep is directly correlated with obesity, especially third shift workers. And interestingly, children who have a planned C-section are 1.77 times higher to have a relative risk of obesity, greater than those delivered vaginally. And that just goes to show that there are so many factors that go into obesity, not just willpower issues. On this next slide, we're going to have a ton of these neurological endocrine changes. Here's some of the hormonal ones. I'm not going to go through all these in detail, but it starts off with leptin resistance, and that's where your fullness hormone is, and so it keeps ramping resistance up and up. You've also got adipokines, which are excreted from the fat and then pro-inflammatory and also cause atherosclerosis. You've got chimerin increase, retinol binding protein for increase, omentin decrease, and that's a protective one that goes down. So you can have this real vicious cycle that when your body finds this new homeostasis, it wants to stay there and has all these epigenetic factors and hormonal factors that promote staying there at that same weight. Does diet and fasting work in obese patients? To a degree, it works in everybody, right? But achieving long-term weight reduction requires overcoming all these neuroendocrine systems that have reached this new set point. So the body loves homeostasis. And if you've been experiencing a ton of food and you suddenly cut back, your body tries to hold on to what it has and also grabs onto anything more you try to put in, and more tightly. It's known to increase circulating levels of cortisol, decrease the levels of growth hormone, decrease the levels of T3, which is your thyroid hormone, and also creates a leptin deficiency signal that just ramps up and up as you go longer in this fasting period that produces a high energy intake response, a binge. And it's basically your body trying to tell you to get some energy, and it's really cranking these signals up in your brain. And about 10% body weight loss, there's a huge deficiency in that, and that's where you notice these imbalances come back in again. Obesity is also an expensive disease. You have more than 200 million people in America considered obese and more than 22 million with severe obesity. In 2019, healthcare costs are almost $2,000 per person higher than a person with a normal weight. And if you have obesity, and if you have severe obesity, it's over $3,000 a year more. And that's before all the GLP-1s came out. But GLP-1 use through 2024. As of 2024, about 1 in 8 Americans have tried a GLP-1, and we also know these are not cheap medications. From 2018 to 2023, spending on GLP-1s rose by 500%, from 13.7 billion to 71.7 billion. Ozempic alone went from 410 million in 2018 to 26.4 billion in 2023. And Mounjaro also saw when it came out in 2022 at 2.5 billion and went up to 12.4 billion dollars in 1 year. And Wegovy went from 580 million in 2021, and that's the weight loss specific version, to 6.99 billion in 2 years. Now, how are all these medications affecting bariatric surgery, which is the most common question bariatric surgeon generally gets asked nowadays? There's been an estimated drop in 10 to 40% of volume with these meds and GLP-1 therapy since their boom in 2022. You see there's a COVID dip back down, goes back up, there's a slight tick down at the end, but that's only until 2022, and it's only gotten a little more severe. Many, if not most patients undergoing bariatric surgery have tried GLP-1s once. As we see the treatments that are available expand, we're going to see the number of patients who've tried something else before this expand. And in 2024, there's about 30% of patients who had tried GLP-1s prior to surgery. In 2020, that was 2% of patients. And we as physicians must treat the disease with multiple approaches and have an appropriate selection for each patient. Now, obesity-related comorbidities. What diseases are driving these costs besides just the medications? So I'm not going to go through every single bit of this, but you have increased incidence of coronary artery disease, obstructive sleep apnea, hyperlipidemia, hypertension, heart failure, kidney disease, NASH, or MAFLD, all higher than in the general population. And as patients age, their body isn't able to cope with that as well. So these compensatory mechanisms decrease, and you see an increase in these comorbidities as patients get older. And obesity-related cancers. There's about 13 directly associated cancers and a few other indirectly associated, and that makes up for about 40% of all cancers diagnosed in the United States every year. And there's new studies coming out every day showing all the diseases that the medicines can improve. You have chronic kidney disease, cardiovascular outcomes, obstructive sleep apnea, NASH, and steatohepatitis. Bariatric surgery improves all these outcomes as well, with improved durability and efficacy. It's kind of the same studies that have been done on those before, and now these new medications are coming out. They're doing the same studies with medical weight loss instead of surgical weight loss. And as far as indications for treatment for both of these, for medical weight loss, it's a BMI of greater than 27 with comorbidities, hypertension, hyperlipidemia, type 2 diabetes, obstructive sleep apnea, sometimes osteoarthritis, coronary artery disease, and NASH, or a BMI greater than 30 without these comorbidities. And you see, kind of similar to surgical weight loss, it's greater than 30 with these associated health programs, or greater than 35 without these comorbidities. And notably, in Asian populations, it's actually shifted down 2.5 BMI points because patients experience these same comorbidities associated with obesity at a lower BMI. Now, you have the medical options from least to most weight loss. Starting off with diet and exercise, it's about 5% total body weight loss at 1 to 1.5 years. You go up to phentermine, topiramate, Qsymia, Contrave. These are non-GLP medications that go from about 6 to 12%. Then you go up to oral Wegovy, which just came out at the beginning of this year. And there's also another oral medication I'll cover on the next page. And that's at about 13.6% at 15 months. Now, injectable Wegovy/Ozempic results in about 15% body weight loss at 15 months. And then tirzepatide/Mounjaro at about 1% total body weight loss at 15 months. And then this one came out as of a week ago. This is Foundayo or orforglipron. This is another oral medication. This is Eli Lilly's version as opposed to Novo Nordisk. It came out and was just approved 2 days ago, and so patients might be asking about that. It's the new one that just came out. Main difference between it and oral Wegovy is that it can be taken anytime, has a slightly different mechanism of action for absorption, so it doesn't necessarily need to have the same, take it at the same time every day with food. Obviously, still a lot to be learned about this one, but if patients ask about it, that's what it is. It has about 1% weight loss less than oral Wegovy, so about 12.4% versus 13.6% for oral Ozempic. Now, with all these medications, should we even be doing surgery? And here's ChatGPT doing its uncanny valley. But how long do patients actually stay on GLP-1s? So 60% of patients stop use for these for weight loss by 6 months, either due to cost, side effects, or being a non-responder, and that's about 10 to 16% of the population. And only about 4% of patients using them primarily for weight loss are still on them at 2 years. And even if patients are on them for diabetes, only a third of them are still on for after a year. And why is that? Kind of like I said before, could be side effects or could be non-responders. And what happens when you stop these medications? So after taking it for 15 months, you average about that 15 to 17% total body weight loss on Ozempic. But when you come off of it, the majority of patients have significant weight regain, back to only about 5% of your total body weight loss. Or if you have a 2-year span of taking this medication for 15 months, coming back off of it after 6 months, if you're 300 pounds, you would have lost about 15 pounds that time on average and spent money on that medication the whole time. But what about new drugs like Zepbound or tirzepatide? Similar to the prior trial, at 88 weeks, patients had similar weight gain as patients coming off Ozempic. So about that 10% at 88 weeks. They didn't carry it up to the full length of the study of the trial, but if the trend holds up, it's going to be about the same. But can we predict who will succeed and who will fail on these medications? So what factors lead to improved GLP responses? Are there non-modifiable or modifiable risk factors? Why are these 10 to 17% of patients non-responders? So female patients are a bit more likely to be hyper-responders to weight loss, but the confidence interval is pretty close to 1. And another one is patients that have a higher baseline A1C are likely to have an increased responsiveness and reductions in A1C. But that kind of goes without saying. If someone's got an A1C of 15 and they get down to 8, that's great. But if someone's in an A1C of 10 and they get down to 8, they only have a 2-point reduction. So it doesn't necessarily tell us a whole lot there. Now, patients with a lower GFR have decreased responses to GLP-1s. And interestingly, depression, anxiety, and sedentary behavior don't correlate with response to GLP-1 therapy. But with increased age, there's decreased benefits with increased side effects. So long story short, we don't know. We're still figuring out what patients are going to be more responsive to these, what patients should be better selected for each medication. Outside, of course, the patients that have black box contraindications of MEN2, medullary thyroid cancer, severe pancreatitis, diabetic retinopathy, and other GI issues. So what are the limitations and drawbacks of these medications? Most studies evaluating these were done in patients of BMI of less than 40, or weigh less than 250 pounds. So outside of this, there's not really many studies that show efficacy for patients greater than that. But like I said, 12 to 17% are non-responders, and that's defined as less than 5% total body weight loss at 6 months. As far as cost and coverage, it's not variable only patient by patient, but from year to year for each patient. And doesn't everybody love doing prior auths? And there's new side effects. So there's class action lawsuits coming out regarding severe gastroparesis, ocular, and other GI issues. So there's a lot that we don't know that's coming out. And there's the generalized risks and side effects. So it's mostly due to gut slowdown. You're putting a stop sign on. You're telling your body that you are full. So your stomach's not going to squeeze. Your colon's not squeezing. Your gallbladder's not squeezing. And that'll lead to a host of issues with gastroparesis, gallbladder issues, severe pancreatitis. And then people don't drink as much water because they feel full. They can have kidney damage. And they don't eat enough protein, so they can have muscle wasting. So a lot of these things you really have to make sure these patients are being taken care of and followed versus just ordering them online per se. And there's also new litigation coming out as of last year regarding specifically diabetic retinopathy and gastroparesis. And weight loss isn't one size fits all. So there's not one answer for every single person. But how do we make the right decisions? Should everyone try their medications? Should everyone have surgery? Are there going to be a combination therapies? Is it just going to be whatever insurance covers? So how can we develop an algorithm for obesity treatment based on weight and comorbidities versus just on insurance coverage and cost? And as the number and patients of GLP-1 increase, what do we need to worry about in our day-to-day practice? These things are increasingly coming from med spas, online, with little to no oversight or follow-up. So how long should you hold injectable medications for procedures? And that's a question that comes up pretty frequently in practice. And right now, there's no evidence to suggest that the optimal duration of fasting. In 2024, they released guidelines that unless the patient has GI side effects, there's no need to hold it. But I think that every GI doc that's here or online, or anybody who does endoscopies, has seen someone who's on GLP-1s. They've scoped after the normal fast of nothing to eat after midnight, but they can eat whatever for dinner, and they still have plenty of food in their stomachs. So how long should you hold these injectable and now oral medications for procedures? The main issue is that we have a long-acting medication that alters gut motility, and we're saying hold it for a week or don't hold it. But I believe the better solution would be to alter what the patient's eating beforehand prior to the procedure, so you're not relying on a change to the physiology of stopping a medication, hoping it comes off rapidly, and the patient's going to want to get right back on it. So if you hold that injection for 1 week, or just happen to skip that dose to time it out nicely. Now, if you have diabetes or if you're on it for diabetes, don't hold it because that's obviously a different indication. Talk to your doctor about that. But nothing to eat after midnight before the procedure, and clear liquid diet for 24 hours before the procedure, so you don't have all that food that's backed up from dinner. Medication interactions and changes. So most of these are mediated by the delayed gastric emptying. So as far as thyroid levels, you might need to monitor them closely when you're starting GLP-1s and possibly reduce the dosage actually, because levothyroxine exposure increases by about a third due to that delayed gastric emptying, and actually has increased absorption when you give semaglutide and levothyroxine. Patients taking oral contraceptives while on tirzepatide or Zepbound are advised to switch to a non-oral contraceptive or to add a barrier method during the initiation phase and any time you increase. This is not seen with the semaglutide, notably. And digoxin. If patients have renal impairment as well, you need to monitor their levels closely, but there's no initial change indicated. Now, enough about all these medications. I'm a bariatric surgeon after all. So how does bariatric surgery compare for weight loss? Now, bariatric surgery produces not only more weight loss, but also more consistent weight loss over time. So with the sleeve, you get about 50 to 60% of excess body weight loss, and that translates to roughly about 25 to 30% total body weight loss. A bypass, 60 to 70%, again, about half of that as far as total body weight loss. And the SADI or switch, 35 to 45% total body weight loss, or 70 to 90% of your excess body weight loss. And you can see these studies are actually measured in years and months, versus being measured in weeks and months like with the medication studies. And you can see that after 7 years, you still have a very sizable decrease of that 20 to 30%. So there's new guidelines that came out in 2022. The previous update was in 1992, and that one was purely based on open surgery with no consideration of laparoscopic or robotic surgery. And the reason for these new guidelines is because they increase safety and efficacy of bariatric surgery. Weight loss surgery is now as safe or safer than many operations, including gallbladder surgery, appendectomy, knee replacement. You can see the perioperative mortality rate of bariatric surgery is 0.08, cholecystectomy or gallbladder removal 0.07, appendectomy 0.08, and knee replacement 0.14. So back when it was open surgery, it was a totally different ballgame. But we've really seen an increase in quality metrics and a lot of safety metrics since then. And interestingly, there's a recent paper that came out about a real-world analysis of bariatric surgery versus medications. Now, previous studies for medications were all in phase 3 trial, very controlled settings, and this is an intent to treat in a real-world analysis of bariatric surgery versus obesity weight loss medications. And you see generally be at 10.3% weight loss for GLP-1s compared to a 28.3% weight loss for surgery. Now, the same paper also went into a detailed dive about cost. So bariatric surgery costs are obviously higher in year one. You have a surgery, and that's a one-time upfront cost, but by the end of year 2, costs are actually lower, mostly from the pharmacy costs in the GLP-1 group. And as you can see here, it tracks along at the bottom, and you end up spending about $11,600 less overall at that 2-year mark, mostly driven by the pharmacy costs versus the one-time cost of surgery. And as far as health outcomes over those 2 years, bariatric surgery is also associated with more comorbidity resolution, less emergency department visits than GLP-1s, and you can also see there's less inpatient stays, there's less outpatient visits, and less emergency department visits. And all of these comorbidities also decrease: hypertension, hyperlipidemia, rheumatoid arthritis, joint disease, depression, coronary artery disease, heart disease, and sleep apnea. We'll also do a brief overview of bariatric surgery options and anatomy, as well as the etymology of the word. Baris meaning heavy, iatros meaning doctor. So the gastric sleeve was initially a bridge to the duodenal switch, and then people didn't come back for the second part of their staged procedure, and people found out they lost a good amount of weight, so that became a primary procedure. You get about 50 to 60% of your excess body weight loss, or 25 to 30% of your total body weight loss, and a hormonal reset with that ghrelin leptin effect. And this is currently the most common bariatric surgery in the United States. Roux-en-Y gastric bypass. So this is the gold standard, tried and true, done since the 1960s. However, the techniques have obviously drastically changed from an open bypass to laparoscopic to robotic bypass. You get about 60 to 70% of your excess body weight loss, or 30 to 35% total body weight loss, And it's also the best procedure for those with severe reflux or gastroparesis. And for those patients that go on GLP-1s and have gastroparesis that doesn't resolve, this is a common surgery they'll convert to the duodenal switch, or SADE, or single anastomosis duodenal ileostomy. This has a larger sleeve gastrectomy and also has a more portion bypassed. So you have a higher weight loss of 70 to 90% of your excess body weight loss, but you also have a higher vitamin deficiency risk. So you have closer follow-up, more aggressive vitamins, but it is the most durable weight loss and comorbidity resolution. There's also the new adoption of the endoscopic sleeve gastroplasty, or ESG. It's just gotten its own CPT procedure code January 1st of this year, and it's particularly beneficial for patients with class 1 and 2 obesity, as well as for those with increasing levels of obesity that just aren't good candidates for surgery. Now, it's got a good safety profile due to the non-invasiveness and has modest effects on diabetes, hypertension, hyperlipidemia, and you do get about the same weight loss, just a little lower than a sleeve, but a little higher than Zepbound. And that's kind of where this sits. It's kind of in a bridge zone there, and you also have less GERD side effects than you do with the sleeve. Now, I've talked all rainbows and butterflies about surgery and have been talking about all these complications of medications. But there are complications of bariatric surgery. So early on, you can have a leak, but it's less than 0.5% and depends on sleeve versus bypass versus SADE. Bleeding is a risk, surgical site infection is a risk, dumping syndrome, as well as increased gas and diarrhea. And that's just from those metabolic changes when you do the bypass portion. Now, about 15 to 30% of patients who get a sleeve will develop reflux. Some of that will go away when they lose the weight and repair the hiatal hernia, but there's still a significant amount. Bile reflux can occur with SADE or any anastomotic procedure, and nutritional deficiency is a very important one to keep an eye on. Because some patients will have had their surgery somewhere else and come over here, and they haven't really followed up, or maybe just taken a Flintstones gummy, and they're not really getting the bariatric vitamins they need. They'll come into the hospital and end up having to stay for that. Marginal ulcers generally occur in patients who are on NSAIDs or smoking, and is one of the risks and can be the bane of a surgeon, as it's right at the anastomosis and you're having to deal with that problem. Strictures fall into that same area as marginal ulcers generally, and fistula is about 0.7 to 6%. So there are risks of surgery, and everybody's seen patients with severe bariatric complications. But the number of these are drastically lower than they were before, and overall, surgery has a higher safety profile. And as we've seen previously, once you're losing all this weight, you end up coming back to the hospital less overall. So we've seen the pros and cons of both, and how can we decide? And why can't we just do both? So how can we stratify patients with obesity to make sure they're getting the treatment they need between lifestyle, meds, surgery, endoscopy, and any or all of the above? So I made this chart to show weight loss percentage by intervention, from lifestyle to non-GLP-1 to the GLP-1s to surgery, and endoscopies in there as well. So who should get medications and how to decide which medications? So studies for weight loss medications, I've said, are generally in lower BMI patients. So the majority of patients are in the 27 to 35 range for their studies and has better efficacy in patients with lower BMIs. Now, if the patient has a BMI of greater than 40, even with a great response to tirzepatide, their BMI still is going to be likely in the obese range. And that's if they're a good responder and stay on it for 18 months. Ideal medical weight loss patients have a BMI of less than 35 to 40, less chronicity of their weight loss, and they can tolerate the side effects. And unfortunately, a lot of this ends up coming down to cost. But what about when patients fail medications? Again, that 12 to 17% are non-responders. And it's reasonable to try a patient on tirzepatide, a stronger medication, if they fail a semaglutide, but generally not vice versa. But if they fail due to side effect intolerance, you can potentially go back to the semaglutide. That's like trialing a patient on pravastatin after rosuvastatin for muscle issues. And if they fail due to severe side effects, then it would be ill-advised to try a GLP-1 again. But I've definitely seen patients that come back in because oftentimes their first question is, when can I restart this medication? And you have to have a very frank and honest conversation with these patients that you're in the hospital because of a complication of these medications, and getting back on these might not be the best option for you. And if patients do fail, that might warrant a referral to bariatric surgery, especially if the patient has a very high BMI. And if a patient has a very high BMI, greater than 40 to 50, medications can be a great bridge to safer surgery, but likely they will overall benefit from surgery. So if you have a patient with an extremely high BMI with no plans for surgery and they're only on medications, it ends up being like throwing a bucket of water on a house fire. What about when patients fail surgery? So the other side of things, about 40 to 75% of patients will end up having some amount of weight regain after reaching their lowest weight at 2 years. And that's defined as going back up 10% from their lowest weight. And the most common reasons are thought to be dysregulated or maladaptive eating, noncompliance to diet, or return to previous habits and sedentary lifestyle. But if the cause is surgical, you can talk about doing revisional surgery, revisional endoscopy, GG outlet revision, or if they have a large sleeve, you can tighten that up as well. But the GLP-1 medications have actually been shown to be very helpful and synergistic. If patients have that weight regain, they lose about all of that weight within 6 months, so faster than they would have if they hadn't had the surgery before. And they're also more likely to keep that weight off after stopping the GLP-1s because it's not like you're giving a temporary treatment and not fixing the underlying problem. You've given them a massive tool and a massive change in their gut anatomy and their gut-brain axis. And if you give them these medications afterwards, it's more of a crutch to get them through to that next part versus treating a chronic issue with an acute change. So we need to be using the right treatment for the right patient. And here's just the BMI scale overlaid with the efficacy of these therapies. So if the patients are in the 27, 28, 29 range, they're not going to get a surgery. That'd be overkill. Now what we can do is get them on medications and see if we can get them down, get them to a better lifestyle. But if they're over in the 50 range, getting them on medications and getting them into the 40 range and saying, all right, this is the strongest medication we have, we're not really doing them a service because they're still in the morbidly obese category. They need to be talked about something more aggressive because every time you do bariatric surgery, on average, that person's lifespan increases by 6 years. So how do we treat patients in a comprehensive weight loss clinic? Now, it's really about putting everything on the table at the first visit. I have a discussion with the patient about all of their options, non-GLP-1 medications, GLP-1 medications, surgery, endoscopy, and if they want to go with medications, that's the direction we can go. And it's also applicable for post-op bariatric surgery patients. But if patients initially want surgery, then that's also the direction we'll go. And sometimes prehabbing with these medications and physical therapy can be the best thing to get these patients to a more optimal state. Now, medicines versus surgery. The most important thing is having structured programs incorporating a pathway to both, meeting the patients where they're at. Because if you have a clinic that only offers medications with no consideration of surgery, you're doing a lot of these patients a disservice. And if you're only offering surgery with no consideration of medications, you're also doing these patients a disservice. So you really have to have a comprehensive center that caters to both. And setting expectations. If patients are going on these medications, it's important to provide clear goals and nutritional support. You really need to set them up to succeed, versus if they were just going to go get it online somewhere, they just have a medication sent to them with a pamphlet. They read the insert, it's good enough, but it really isn't. And what we do is have patients sign a weight loss contract, like a goal of losing 10% of your weight loss over the first 6 months. They'll have monthly visits, some with me, some with a dietitian, and really make sure you're staying on track. And if not, then you can discuss what's holding them back before you hit that 6-month mark and you've just been spinning your wheels in mud. And if these aren't working, we can revisit the topic of more aggressive intervention, endoscopy, or surgery. And the takeaways of this are that obesity is a highly prevalent, stigmatized, and expensive disease. It's a chronic, relapsing disease that requires a multifactorial approach. There are amazing medications coming out, but patient selection is key for success on these medications, and utilizing an approach based on BMI and comorbidities is key to selecting therapies for the appropriate degree of disease. Bariatric surgery remains the most effective, durable, and cost-effective treatment. So there's no one cure for weight loss, not one path for every patient. And we as healthcare professionals have to be aware of all the options to treat the most prevalent disease of our time. Any questions?
Yes. Nice job. Thanks for the update. Of course. Can you go back to the complication slide or whatever? I didn't see bowel obstruction on there. What are your comments on that? I feel like that's something we see after root wise, especially.
Yeah, like for like an internal hernia.
Yeah.
Yeah,
Exactly.
that rate's also similar to that marginal ulcer rate, where you generally have that 1.2, and it's also dependent on, it's very surgeon dependent. In the past, people used to say, I don't have to close these defects, and then you obviously have a lot higher risk. Now we know that closing the defects is important, and that rate has gone down. But obviously there's patients here that have had surgery 20 years ago, and they could present with an acute internal hernia then. But that's around that kind of that 2.5% range. Again?
Magnetic anastomoses. I've been reading about it and it's kind of newer. Any comments on that or thoughts, or have you used it?
I haven't used it. I think it's a really cool technology. And I think that right now, since you have to basically do a surgery to put them in, it's in a lot more of an investigative phase. There's been a lot of studies in India and a lot of patients that have gotten it in India that show a lot of really promising results. I think it's going to be a high barrier to get it into the US. But I think it would reduce the risk of marginal ulcers and strictures because you have a little more of a, I don't know, the data has shown that they have less strictures and marginal ulcers, I guess I would say.
I thought there's a company that they got approved and are doing them in the United
I think it's
States.
GI Windows, and they're just now starting clinical trials, and there's a couple based out of Houston,
Okay,
but nothing that's going to be on the books for at least a couple years.
sure, yeah, okay. Thank you.
What are your thoughts on intragastric balloons?
So intragastric balloons, not great personally. So it's even more temporary than any of these medications. It is a one-time cost. You have to do an endoscopy, and then patients lose about, I think it's 8 to 10% of their body weight, and then the balloon comes back out and they gain it all back. And then they realize that they've paid $2,000 for very, very temporary weight loss. And I think with the era of GLP-1s, that's going to kind of go the way of the dodo.